Okay, well, everybody is joining on. We're going to go ahead and just get started. It's right at noon. So welcome to our project scope session today. Again, if you've not taken a minute, please put your name and contact information into chat. As you saw, we are recording today's session. We use those for educational and quality improvement purposes. They are shared on our Canvas page as well as our YouTube, so that you can go back and watch these at a later date. We'd love to know who is on our call. So if you please take a minute and just change your name so we can see where you're from, who's joining our call, what your discipline is. It gives us a nice perspective of who's on there, and as well as knowing who we could reach out to if we have any questions, or other participants can also reach out. ECHO is a really interactive community. We hope that you'll put information and questions into chat, raise your hand, engage with us, engage during those case narratives that we do. Again, if you're interested as well doing a case narrative, it is a really great way to gain more information for the families that we're working with, the situations that we encounter on a day-to-day time with what we do. If you've never joined an ECHO session before, there are key components of an ECHO session, and one is just that building that community of practice. So sharing our knowledge. We have an amazing speaker today, Dr. Camille Fung, who is sharing some of her wealth of information with us. So she is our didactic speaker. We then also do a case presentation and do small breakout groups for feedback. Today we are not doing a case presentation because we are learning some of the basics of that NAS and NOWS. If you're interested in doing a case study, please reach out to Project Scope at USU.edu or any of our amazing hub members on the team, and you can see them they all have an asterisk in front of their name. So you could also reach out to one of them. In order to get a credit for attendance or a certificate, we do ask that you fill out the survey evaluations. Those again give us valuable information that allows us to keep these trainings for free, and that we can go back and share what we're learning from it. So I will be putting the Qualtrics survey into chat throughout the session. You'll take a minute before you leave us to complete that survey. We'll also go out in a post email. Canvas is where we store all of this information. You should get a invite all the time with our Canvas after each session, but if you do not and you would like one, just reach out to Project Scope at USU.edu, and we do try to respond pretty quickly on getting those Canvas invites out again. Canvas is also a great way to do discussion boards. So if you heard somebody say something like you were really interested in what a comment Becky made, you can even post that on the discussion board, since we don't always have other participants' emails. If you've not taken a minute, follow us on Facebook and Instagram. We share resources, upcoming sessions, any information that gets passed to us from other program communities, other states, anything with new and latest information. So it's another great tool for that. Again, thank you so much for joining us today. I'm going to give just a little bit of information that our next session will be March 8th. Before I stop sharing and turn the time over to Dr. Camille Fung, who is coming to us from the University of Utah, and I will let her take it away.
Oh boy, what happened to there it is. Can you guys see my screen?
We're seeing your presenter view mode, so we'd see your notes. So
I have two screens going for some reason. Okay, Let me see. Hold on.
It
Oh,
never
my
fails. We
God.
practiced it beforehand and it works so smoothly, but then we all get nervous once we get on here.
Oh gosh, how can I get this going here?
Bailey, do you want to walk her through how to helping with that?
I'll just, here, let me exit
Yeah.
and try again.
Okay.
That's what
Let
I was
me-
gonna suggest.
Yeah, start over. Okay,
It's the typical IT answer. Turn it off and back on again and hope for the best.
yes. Okay. Does that work?
Yep, that's perfect.
Okay. All righty. Well, thank you again to Project Echo for inviting me. I think this is the third year that I am speaking in this forum, and I'm humbled because I've learned a lot just taking care of this population of patients. And I hope that in the next hour or so, I can endow some knowledge through what I've done and taking care of these babies in the NICU at the University of Utah. Plus, Intermountain too, I attend at IMC and Primary Children's. So I have nothing to disclose. And these are the learning objectives for today. And my slide set is for the most part similar to what we have presented the last couple of years. I have updated certain slides and I will definitely point those out to you guys if you previously attended. But my objectives really remain the same. To define the prevalence of neonatal opioid withdrawal syndrome, which is actually now termed as NOWS instead of neonatal abstinence syndrome. We will talk about the prevalence nationwide as well as in the state of Utah. We will define the clinical features of NOWS and illustrate some of the management protocols that are currently in use while the babies are in the hospital to manage their symptoms. And we'll definitely talk more about the Eat, Sleep, Console treatment algorithm. And this has become a big part of inpatient treatment, and we'll go over why that occurred. And the University of Utah actually is one of the sites who participated in the NIH-sponsored ESC trial, and the manuscript is currently under revision at the New England Journal of Medicine. So I think you're going to hear about this in probably the next 1 to 2 months. So I'll give you a sneak preview of some of the results that we have. Okay, so let's dive in. And actually, I'm going to ignore the chat for the moment, but if you guys have questions, feel free to interrupt me and I'm happy to answer them as we go along, or you can wait till the end as well.
And Camille, we'll go ahead and also monitor that chat, and so you don't have to worry about that and interrupt you. So
thank you. Okay, so you know, this issue of neonatal opioid withdrawal syndrome revolves around opioid pain relievers, which are shortened as OPRs in this presentation. And the US definitely has experienced a surge in opioid use and opioid-related complications. So from 1999 to 2009, there was actually a quadrupling of OPR prescription sales nationwide. And by 2015, there were 3 times as many prescriptions for OPRs that were filled than back in 1999, reaching about 1/3 of US adults using opioid pain relievers. And so this has been associated with a parallel increase in OPR-related treatment facility admissions as well as overdose deaths. And some of the kind of scary statistics that I can quote for you is that since 2011, deaths from OPRs have actually plateaued, but deaths from heroin and fentanyl have grown exponentially. And in 2017, almost 50,000 Americans actually died of opioid overdoses, outnumbering car crashes and firearms. So the CDC actually estimates that the total economic burden of OPR misuse alone is close to $80 billion per year. And this accounts for costs of healthcare, lost productivity from work, addiction treatment, and criminal justice involvement. And some of the more commonly prescribed short-acting opioids that are being prescribed for a legitimate reason include codeine, hydrocodone, and oxycodone. And people always compare these drugs to morphine equivalency to kind of gauge their potency. So codeine is about 1/10 as potent as morphine. Hydrocodone is just as potent as morphine, and oxycodone, which is a lot of times prescribed post-operatively, is actually 1.5 to 2 times more potent than morphine. And then we also have the long-acting opioids that are the methadone and the buprenorphine, and those are typically used to stabilize opiate withdrawal symptoms and what we call maintenance-assisted therapy. So I would say the OPR use has definitely plateaued, and I think as practitioners, we are very aware of addiction issues nowadays and have gone through lots and lots of training to curb the number of prescriptions that are being prescribed overall. But I think the culprit nowadays has really turned into illicitly manufactured fentanyl. So fentanyl is a synthetic opioid that is used to treat severe pain. And we just talked about equivalency to morphine. Fentanyl is actually 50 to 100 times more potent than morphine. So this is the drug that is being circulated on the streets nowadays, and that's pretty scary. So the illicitly manufactured fentanyl in particular is causing the most number of cases of recent fentanyl-related harm, overdose, and death in the United States. Oftentimes, the drug dealers will mix this in with heroin or cocaine or methamphetamine to try to increase the euphoric effects when a person purchases these street drugs. And it's super dangerous when the individual is actually unaware of the presence of these products that are mixed in. So back in 2019, in fact, 85% of the drug overdose deaths in 24 states and the District of Columbia was attributed to illicitly manufactured fentanyl. So because of the increases in opioid misuse and overdoses, particularly relating to pregnant women, this has led to an increase in neonatal opioid withdrawal syndrome, or NOWS, and has also increased in injection drug use, which has led to the spread of HIV as well as hepatitis C. I would say across the country, there's no universal screening of hepatitis C. I think in the state of Utah, a lot of the prenatal labs do now include hepatitis C instead of in addition to hepatitis B. So that's good for detection and screening. And what is known about hepatitis C transmission from mother to infant is about 6%. Unfortunately, if the mother was co-infected with HIV, the transmission of hepatitis C goes up to 11%. And there are certain states across the country where hepatitis C infection has really dramatically increased. One state would be West Virginia, again, correlating with an increase in opioid use. So from 2009 to 2014, the rate of hepatitis C infections actually doubled to 3.4 per 1,000 live births, and even as high as 1 in 50 live births in West Virginia. So neonatal opioid withdrawal syndrome, since this is sort of what we're here to talk about mostly. I know a lot of the slides that are upcoming, you may have knowledge of this topic pretty well, but I think it's worthwhile just discussing it a little bit further in depth. So this NOWS term has now replaced the neonatal absence syndrome, or NAS terminology in the literature. And what NOWS describes is neonatal symptoms that are occurring after in utero exposure to opioids alone or in combination with other non-opioid substances. So as long as you have opioid in the exposure for the babies, it's going to be called NOWS. Versus if you have non-opioid exposures alone, like your SSRIs, your antidepressants, typically now referred to as neonatal discontinuation syndrome. Unfortunately, though, babies who have been exposed to opioids, what has been described in the literature is that up to 94% of them will develop withdrawal signs and symptoms. So it's going to be a lot of babies who are potentially going to be affected, but the severity is the piece that is unknown. So again, many of you are probably familiar with the clinical features of NOWS, and I think of them really as three big systems that are affecting the baby. So there is neurological excitability, and this category is manifested by hyperactive primitive reflexes. They are irritable, they have high-pitched cry, they have sleep-wake disturbances, they are hypertonic, and they are tremulous. And the worst case scenario is that if they actually develop seizures. Then you also have your gastrointestinal dysfunction. So I think of these as having feeding difficulties. And so a lot of times these babies like to suck, and it's not uncommon they eat a whole lot of food just because if you put anything in their mouth, they would just suck away. But actually having uncoordinated suck and swallow on the other extreme is also a common symptom of withdrawal. And then if they can also have vomiting and diarrhea as well. And lastly, the category that I kind of think of as autonomic signs are things that you can observe pretty easily. They can have fevers, they can be sweaty, mottling, yawning, nasal stuffiness, and sneezing. So these are kind of the three big categories. So what is the problem with having all of these symptoms? Well, they actually put the baby at increased risk for having failure to thrive. So that's why we want to make these withdrawal signs and symptoms better so that these babies can actually proceed with daily living. So these clinical features that we just talked about, it's actually, there are so many levels of metabolism that eventually govern how bad their withdrawal signs and symptoms will be. And it's very different. You know, you can see two babies, for example, with the same exposures, and yet one may do okay and one may not. So why is that? I think it just speaks to the very varied levels of drug metabolism and exposure. So even the mom's own history, right? So if you have a combination of illicit drugs and she smokes and she also has some prescribed opioids, that's a different scenario than a mom who's just taking a maintenance assisted therapy, for example. And then the mom has her own drug metabolism. So we now know that there are variants, there are SNP microarray variants as how well an individual will clear a drug from the system. So that plays a part. And then there's also the placenta, right? So even a mom, she intakes whatever substance that she is taking in, there has to be a net transfer of that drug across the placenta in order to get into the fetus. So the placenta tends to be an organ that really tries to protect the baby. So there are definitely receptors and enzyme systems of its own that tries to deal with the substance exposure. And then that speaks to the placental metabolism piece. And also the baby, partly reflecting paternal metabolism, will have its own way of handling the substance that's being transferred. So I think overall, the bottom line to remember is that it is actually very difficult to predict which baby will withdraw, for how long, and how severe, especially in light of polysubstance abuse, which is what we typically see nowadays. So I put this slide in because I think it's kind of important. If you haven't been reading this literature for the last 20 years, it might be important to kind of go over how this opioid crisis has transpired over the last 20 years. So I'm going to cite you a whole bunch of studies, but it shouldn't be too encompassing. So I think the first study that really highlighted that this is a prevalent issue was actually published in JAMA in 2012. So Stephen Patrick is a neonatologist at Vanderbilt University, and he has pretty much dedicated his whole life looking at neonatal opioid withdrawal syndrome. So he published a paper back in 2012 that looked at neonatal, so this is older literature, so I'm going to use NAS and NOWS interchangeably just because I'm giving you older literature that's still using NAS as the terminology. So he looked at NAS and the associated healthcare expenditures spanning the years of 2000 to 2009. And he did this based on a really large set of hospital data. And what he found over those 9 years was that if you look at the rate of NAS per 1,000 hospital births, he saw a 3-fold increase in NAS during that study period. And then he did some interesting calculation and figured out that back then, 1 baby was born every hour in the US who was suffering from neonatal abstinence syndrome. Parallel to that is the maternal opioid use. And so for that same cohort of mother-infant babies, they found a 5-fold increase in maternal opioid use. And this table looks at both the mean hospital charges as well as the length of stay for that same cohort. So what I'm going to highlight for you around the boxes is that if you look at the length of stay in the top row, which is length of stay relating to neonatal abstinence syndrome versus length of stay for all other US births, you can tell that over time, well, first of all, comparing the two, if you have an infant suffering from NAS, you're going to stay a lot longer than if you were kind of just a regular vaginal or C-section delivery. And over time, in the last, from 2000 and 2009, the number of days seems to have been slightly increasing. And this is an expensive hobby. So if you look at how much is being charged for keeping these babies in the hospital, again, it's a lot more than if you were a baby who was just undergoing a regular birth without complication of NAS. And so about $40,000 to $50,000 is spent on treatment for NAS in the hospital. So what they calculated was that the hospital charges actually quadrupled, even adjusting for inflation. And so who are all of these babies that are being cared for, and what insurance system? So again, unfortunately, is the Medicaid population that is impacted the most. And so the majority of these babies are insured under Medicaid compared to a private payer or self-pay. So if we move forward time a little bit, this is another paper that was published 3 years later by Tollier et al. And again, they're just describing the rising incidence of neonatal abstinence syndrome. And now we're covering the periods of 2004 to 2013. So the cumulative incidence has gone from 7 per 1,000 admissions to the NICU that are related to neonatal abstinence syndrome to 27 per 1,000 live births in that 9-year period. And again, the length of stay continues to increase as we are having to take care of these babies for longer in the hospital. So the overall message from this paper was that neonatal abstinence syndrome increased from 0.6% to 4% of all the admissions in the NICU. But there were 8 centers who actually reported more than 20%. So a fifth of their NICU stays is actually attributed to neonatal abstinence syndrome. And from this paper, they now have redefined that every 25 minutes instead of every hour, a baby is born suffering from neonatal abstinence syndrome. So again, marching further another 3 years, Winkleman published a paper in Pediatrics. This is a really, really huge data set. They had 13 million hospital birth data from the NIS sample, so National Inpatient Sample. Again, looking at the years of 2004 to 2014. Again, Medicaid covered patients constituted the majority of NAS-related births in that time period. And then Medicaid covered infant is more likely going to be transferred to another facility to manage their withdrawal symptoms, which prolongs the length of stay. And adjusting for inflation, the total hospital cost continues to increase from $65 to $462 million per year. And in this paper now, we are seeing one infant born every 15 minutes who is suffering from NAS. So this is, I would say, the last and the most recent paper that has delineated neonatal absence syndrome and maternal opioid-related diagnoses in the U.S. So they're covering the periods of 2010 to 2017. Again, looking at the NIS National Inpatient Sample. And I know this looks really busy, but again, I'm going to put a box around some of the demographics so that you can see what populations are actually getting affected by neonatal abstinence syndrome and maternal opioid related diagnoses. So if you look at this cohort, the majority of mommies who are getting affected, mommies and babies, are non-Hispanic whites. The most common is in the age range of moms being 25 to 29. Again, to no surprise to people, the primary expected payer for these belong to the Medicaid system. And again, kind of concurrent with the Medicaid system is that they belong to the lowest income quartile. And this is a big problem for, this is not just a rural problem. This affects everyone. So even the large metro areas are the ones that are impacted the most. But I would say that's not it. A lot of the even rural counties are also getting affected. So if we break down to the NAS piece alone, right, we just look at neonatal abstinence syndrome per 1,000 hospital births. So again, if you just scan your eyes across that row, the incidence seems to be continuing to increase over time. And like I mentioned before, both large and small metro areas are increasing over time. But I also want to highlight that the non-metro rural areas are actually increasing in a much faster pace that we're seeing in the metro area. So I think it is really important, a conference like this where project scope can be reached to rural areas, that people are actually kind of dialing in and getting some education about a topic such as this one. So this is the same kind of data, but looking at maternal opioid related diagnoses. Again, if you span your eyes across the time, there is continuing to increase of maternal use of opioids, and the non-metro areas are the ones that are significantly going up a lot faster than the metro areas. I don't know if this is a little glimmer of hope, but if you actually look at the length of stay and the cost of treating these babies over time, it looks like maybe the length of stay, the median length of stay is kind of plateauing and maybe heading down a little bit, and we can hypothesize why that may be, and we'll talk about that later on. And the cost of keeping these babies in the hospital also may be starting to plateau, because I think we have better way of managing these babies inpatient. And for those who like maps, and my husband is a big map person, he will pick up a map and stare at it for hours. But these are just what we call heat maps. So these are maps relating to neonatal abstinence syndrome, and the darker you are, the worse you are. So panel A on the left is just the overall NAS rate per 1,000 hospital births, and you can see that the West Virginia has a huge problem, right? It's just that dark color really jumps out. And then panel B on the right is the percentage change over those 7 years. And so again, darker is not good. And then these are the maternal opioid related diagnoses. So it is not a Utah problem. This is the problem that is all over the United States. And I think we can all appreciate that. So any questions so far before I jump into kind of management for neonatal opioid withdrawal syndrome? Any questions on the epidemiology? Okay. If you do, just stop me. So because of the skyrocketing increase in NAS, the American Academy of Pediatrics actually came out with actually now two clinical report guidelines. The first one was published in 2012, and it was recently updated in 2020. And so, to no surprise to anyone, every nursery should have a policy for assessing maternal substance abuse and have a standardized plan for the evaluation and management of infants at risk for or showing withdrawal. So I think a lot of these efforts to try to unify practices and harmonize practices is one way of trying to make this length of stay and cost of hospitalization better. So at the University of Utah, I know everyone does it a little bit differently, but this is kind of the algorithm that we go through every time we see a drug-exposed newborn. And so we try to confirm the maternal history. And I would say a lot of moms, despite the stigmatization associated with substance use disorder, if you actually are open and have an honest conversation with them and about how you're concerned about what their in utero exposures are and how that would impact the infant, and you really need to know so that you can do the right thing for their baby. A lot of moms are actually pretty open about telling you what they have and haven't done. And I think the key is to do it in a very non-judgmental fashion, taking kind of her baby's best interest at heart and as well her interest. And so that's what I try to teach my trainees all the time is just don't judge, just go in there, be honest, and have a good heart and just really figure out what's been going on and what her drug exposures are, because that will impact how we treat those babies in the hospital. Oftentimes though too is we do perform some kind of drug testing. In the past, we relied on urine drug testing and meconium drug testing. Urine is really only good for exposure for the last 72 hours. And so if the mom actually came into labor and delivery and hadn't done anything for over a week, if you get a baby's urine, you may not actually see anything. Meconium is a little bit more sensitive. It reflects exposure from about 20 weeks on. So if you're able to get baby's first poop collected, that's a good way. However, the latest tissue of choice, I would say, for us in the hospital is actually the umbilical cord. The umbilical cord, similar to meconium, reflects about 20 weeks of gestation of exposure onwards. So it is a good piece of tissue that you can use. And sometimes, for example, for a preemie who doesn't poop for a while, you may not have the meconium, or you have a term baby who actually passed meconium in utero because of stress. You may have missed that opportunity. So that's why I think a lot of hospitals now have gone to the use of an umbilical cord, because every baby will have an umbilical cord. And also we make a referral to social work early. And I think that's important because there could be court proceedings down the line, assessing home safety. So I think it's very important that we involve social work early when we know that we have a drug exposed infant. And then while they're in the hospital, I think one of the reasons that we want to know as best as we can what the exposures are, it guides you on observation. So how long do I actually watch that baby for in the hospital? Right? Nowadays, insurance companies is always trying to kick people out of the hospital. So you have to have a way of understanding and some kind of evidence to argue for keeping the baby for longer than usual. So again, at the University of Utah, if we know that they have opioid exposure, we try to understand, are we just dealing with short-acting opioids? Are we dealing with long-acting opioids? Are we dealing with both? And so short-acting opioids are the ones that are kind of like the common things that are prescribed, like hydrocodone, oxycodone, hydromorphone. Heroin is short-acting. Fentanyl on the street is short-acting. So those babies would typically actually try to keep them and watch them for 72 hours because they should be presenting with signs and symptoms by that time. Versus long-acting are your buprenorphine, your methadone, and some of the extended release short-acting ones. We keep those babies for up to 96 hours, so a 4-day observation period, to really try to capture the majority of the infants who's going to have issues and may need pharmacotherapy. And then if you actually don't have opioid exposure, if you're dealing with some of the stimulants like cocaine, methamphetamines, antidepressants, antipsychotics, those babies typically can still withdraw. We call it discontinuation syndrome, like we talked about earlier, but typically they do not need pharmacotherapy. So it's really non-pharmacological means will be sufficient to actually get them through their discontinuation syndrome. Okay, so let's talk about non-pharmacological care, because I think this has now become the forefront of inpatient management. And I think that's just what has to be. I think blasting these babies postnatally with more and more morphine isn't going to be the way to get through withdrawal. There are cases when we do need it, but I think we really gotta bring non-pharmacological care up front. So this should always be the first line of treatment for any drug withdrawal or discontinuation syndrome. Again, like I said, non-opioid exposures typically don't need pharmacology to help. And so we've even gotten a way of trying to score the symptoms. We just try to make sure that they're able to eat, sleep, and rest. So we'll talk about that later. And I think it's also important to understand, their symptoms, right? If they are hyperactive and having a high-pitched cry and they've just gotten away from having nicotine from their system, I think that makes a lot of sense. So you kind of have to understand, are their symptoms making sense for what the exposures, at least the known exposures are? And if it doesn't, then you have to worry about something else that's going on that may be not drug withdrawal related. So I think it's important to look at the infant behavior in the context of the type of exposure. And this is a piece that I think we have to do a lot better in the hospital too, is that educate the moms and the dads and whoever is going to be participating in the care of this infant. You have to teach them about what the signs of exposures are and what the calming techniques are that work for that particular baby. Every baby may respond to a different calming technique. And so while the caregivers are in the hospital, we should really work on educating them and empowering them to know how to calm that baby while they're going through a withdrawal period. So some of the things that we do for non-pharmacological care, and again, I'm sure you guys are aware of these, is swaddling with some soft blankets can help. Keeping in a quiet, dark environment, at least for the period when the baby's overstimulated. Using frequent small feedings of hypercaloric formula is kind of controversial. So, as you all know, breast milk is around 20 kcals per ounce. And so because these babies are hypermetabolic, meaning that because of their withdrawal symptoms, they are burning a lot more calories. And so it is not uncommon that we have to go to 22 calories per ounce or even 24 calories per ounce to try to prevent them from losing weight further. So, but that's a topic that some people will argue that maybe we should push more volume rather than calories. So that's up for debate. You can try a pacifier. Kangaroo care works beautifully if the caregiver is able to be at the bedside. And I think for nurses and for us providers who are trying to examine those babies is to try to organize care so we're not continuously examining them and unbundling them and disturbing them. Swings, I put swings on there. Sometimes it is helpful. Sometimes it's actually too much for a baby who's having severe withdrawal. So you just have to see what works. And like I said, cluster care and daily examinations, and bottom line is determine the level of stimulation that the baby can tolerate. When the baby's in the NICU or in any kind of nursery, I think a lot of us will do involve our developmental team, our occupational therapists, our physical therapists. And so this was a very nice sort of figure that I found in an article that looked at the 4 specific infant neurobehavior domains that I think as a developmental team, you guys are not consciously thinking them as 4 different things, but you're probably assessing all of these in your management of these babies. So basically reactivity to sensory stimulation and respiratory issues, behavioral states and state control, motor and tone control, autonomic signs of stress, all of these should be evaluated, and recommendations should be made based on all of these components of the neurobehavior. So there's the infant neurobehavioral functioning that we should look at. We also look at maternal functioning, right? So does the mom actually have a psychiatric condition that is not being cared for, and we should make a referral? Does she have previous trauma exposure? She might have a different ability and sensation to pain. All of these things that I think if we try to get an understanding of where the mom's coming from, it may also help to augment the non-pharmacological care. And lastly, the environment and the provider of itself. So rooming in, we're definitely advocating for moms and dads to room in as much as possible nowadays. Again, I think a lot of these families, they worry that people are judging them. And so we just have got to get away from that. We just got to be inclusive and get them into the process as part of the team to help this baby through his or her withdrawal. And so that's what we should advocate for.
Dr. Fung,
Yes.
there is a question in the chat.
Yes.
Is there any research you know about regarding the use of music therapy for these babies?
Absolutely. I did not even talk about that, but there are actually both research studies as well as non-research studies that have shown it is helpful to use music therapy. What kinds of music they use, unknown, but I think most of the time people play soft sort of classical music. But I guess if you're a baby who likes rock, maybe that would be the brain that you want to be listening to, or the type of music your brain will be listening to. But definitely music therapy has been shown to be helpful. So that's a good one. Okay, and then I think in terms of breastfeeding and the use of breast milk, I think that is something that is absolutely helpful. It is, in fact, the most studied non-pharmacological intervention that we can provide for a baby with withdrawal, with some caveats though, right? So if the mom is HIV positive, at least in the developed countries, we do have this as an absolute contraindication. And then if you check the drug screens, I think at the moment, illicit drugs, so street drugs, are still a contraindication for using the mom's breast milk. And I cannot even talk about marijuana at this point because that's a whole lecture by itself. The destigmatization of the use of marijuana in many, many states have actually become a problem, because I think sometimes pregnant mothers are thinking that this is safe, and I would say safety has not been demonstrated just because it's now legal and destigmatized. So at the moment, the American Breast Milk Society, American College of OBGYN, and the American Academy of Pediatrics still discourage the use of breast milk with marijuana. But again, we can talk about that in questions and answers if you guys have any. So in moms who are in treatment programs, the American Breast Milk Society actually published some consensus breastfeeding guidelines that suggest that breast milk should be encouraged if a mom has not had a relapse in more than 90 days from delivery, but should be discouraged if there has been a relapse within the last 30 days of delivery. So again, that is a recommendation that they have put out. Not all the hospitals are adopting that recommendation. At least at the university, we are taking this stance that if you have been in treatment and you've been faithful, you've had negative drug screen, it's been more than 90 days. We don't see, and there's no illicit drugs, we don't see why your breast milk shouldn't be used. A question I get a lot is it safe to breastfeed with methadone and buprenorphine? And it is. If a mom's on maintenance assisted therapy, go ahead and use her milk. It does not prevent that baby from having neonatal abstinence syndrome. In fact, some studies will say that it would be actually helpful to lessen the withdrawal symptoms. And overall, the concentration in breast milk are very low and not related to the maternal dose. And anytime you have a concern about what's in the breast milk, you know, whether it's a medication or something else, these are good resources that you can actually tap into. Dr. Hale has been studying medications in breast milk for, I don't know, 30, 40 years. And now he used to be a really thick textbook that we all carry around, but now everything's online. And then LactMed is a NIH sponsored website that also tries to give updated information on safety of substances in breast milk. Okay, so let's go back to opioids, right? So the short-acting opioids really has been the culprits of addiction and misuse over the last 20 years. And like I said, oftentimes it's prescribed for a legitimate reason, but people get addicted to no fault of their own. I think everyone has a slightly different level of addiction threshold. And as these opioid-dependent users have no more access to their prescriptions, sometimes they are going onto the street to look for heroin as a temporizing measure. And like we talked about, heroin may not be pure heroin nowadays. It could be laced with other drugs, and fentanyl is one that is notorious nowadays. And be aware of polysubstance use because that is the majority of our mothers. This is a really old paper published in 1957. So the reason I put it here is that sometimes people ask me, well, you know, you talk about watching a baby for 3 days, 4 days, but exactly how long are they going to be out of the woods for? So this really, really old paper, at least for hospitalization, they say that if more than 1 week has elapsed since the last maternal dose and delivery, then the incidence of NAS is actually relatively low. So not saying that you should keep your babies for over a week, but whatever time of observation you decide, just know that once the baby's out of the hospital, that baby should be seen within the next 1 to 2 days because you're definitely not out of the woods right away. And then just a few slides on the long-acting opioids. So methadone, many of you are very aware of methadone. It has been the standard of care for opioid addiction management since the 1970s. Unfortunately, it's only administered under a medication-assisted treatment program with very strict rules. So you have to get there first thing in the morning. You have routine drug screening. And so it has been a little bit prohibitive for a lot of mothers, actually, who are trying to get clean, but just can't get to these methadone clinics, which is why buprenorphine products have really come on board to try to be a way of easier access for mothers who need MAT. So buprenorphine, what is it? It's actually a partial mu opioid receptor agonist and a partial kappa opioid receptor agonist. Oh gosh, what does that mean? So if you're looking at the opioid receptor agonist piece, that's the piece that is typically what people are using it for. So at low doses, buprenorphine has an agonist effect, just like, you know, morphine and heroin and all the other opioids that we talked about. It gives you pain relief, it gives you some euphoria and things like that. But at high doses, you actually get a receptor activation plateau, meaning that just going up higher does not mean you're going to get more of those effects. You can actually reach a ceiling effect. So basically, you don't need a really, really high dose of buprenorphine in order to temporize withdrawal symptoms. Buprenorphine comes in different formulations, and I think it's just important to know what they are. So the brand, some of these brand names are Buprenex or Subutex. You probably heard of these. And so this is basically buprenorphine alone with no other additives. However, many buprenorphine prescribers actually use Suboxone, which actually is a combination of buprenorphine and naloxone in a 4-to-1 ratio. So the dose of naloxone, which is actually the antagonist piece. So a person that you find on the street who is overdosed with an opioid, you can actually give them naloxone right now nowadays to actually try to reverse their comatose state. But naloxone orally, which is what these pills are, is actually a not very effective way of reversing opioid overdose. So it's not well absorbed sublingually. It's the reason it's put in there is really just it's a way of avoiding opioid diversion. So if somebody stole a pill from somebody else and there's a Suboxone pill and you crush it and you try to inject it into your vein, you will actually get an immediate withdrawal. So it's really a way of diverting opioid use. Buprenorphine during pregnancy has been shown to still cause some neonatal absence syndrome, but the course seems to be shorter and milder. And it may be related to a lower opioid equivalent dose. So that's why with all of these benefits, it's become kind of the drug of choice if you're going to give it to a mom for maintenance assisted therapy. So this is brand new. Congress just passed a law back in December 29, along with their budget. So this is the Consolidated Appropriations Act of 2023. They have eliminated the data waiver program. So what that means is that in the past, you used to have to apply for a buprenorphine waiver. And you have to go through all of these hoops in order to be a buprenorphine prescriber. But now with the increasing opioid crisis, they have gotten away and they've done away with this waiver. So basically, anybody who has a DEA license will be able to prescribe buprenorphine. You don't actually need a particular buprenorphine waiver. And there used to be a ceiling on how many prescriptions you can give. That has also gone away. So the DEA, this is their goal, right? Their goal is simple. They want medication for opioid use disorder to be readily and safely available to anyone in the country who needs it. So the elimination of the X waiver will increase access to buprenorphine for those in need. So that was their goal. And so as of now, you can go to any prescriber and get a buprenorphine for your patient. So we talked a lot about non-pharmacological means. So why do we even need to use pharmacology to treat these babies? Well, I would say that there are babies who just have such severe withdrawal that just non-pharmacological maneuvers are insufficient. That's the time when you actually need to give them something. And the goals, here are the goals, right, is to try to relieve symptoms that are interfering with their physiologic stability, their ability to eat and gain weight, the ability to be consoled, and to actually have a good amount of sleep. Also, I think another goal is not just baby targeted, is to as a way to improve mother-infant interactions and bonding. So a baby who's screaming at the top of his or her lungs is going to be very stressful for a mom or a caregiver. So maybe giving a little bit of morphine, for example, will just take the edge off so that some of these other things can happen normally and will de-stress for them all. So like I said, morphine typically is the most common first-line therapy across the US for treating severe NOWS. And we have all kinds of dosing regimen, just one that I have put up here. There's both IV and oral dosing available. There are certain centers who don't use morphine, but they use the longer acting opioids, the methadone and the buprenorphine, but that's the minority. Again, both of these have their own dosing regimen, and buprenorphine really has not taken off, unfortunately, in the neonatal population, partly because the formulation that's around has a very high alcohol content. And so you would have to basically design a clinical trial that allows you to make one that doesn't have a high alcohol content, because the readily available formulation does. And both of these drugs have shown to reduce the duration of treatment and length of stay. But unfortunately, they've only been given in the setting of a rigorous study protocol and included only with women who are in opioid use disorder treatments. So it just speaks to the lack of generalizability of these two drugs to our treatment algorithm. And if that's not sufficient, we at the university, we even use clonidine or phenobarbital as adjunctive therapy to morphine. And again, we can, you don't have to know the details of the dosing, but these are other medications that are available. A question I get a lot is the length of hospitalization and treatment. How long will this baby withdraw for? How long do we keep them for? And I would say I don't have a magic ball to tell you exactly how long, but it's highly variable. In order to get them out of the hospital, I would say that we need to focus on their ability to have good sleeping periods, the ability to gain weight, and the ability to be cared for by a reasonable layperson, right? So a nurse at the bedside, a NICU nurse at the bedside is got to know what to do. But a mom who actually has never been parented by her own parent may not know what to do. And so these are the things that you have to teach her while she's in the hospital with you. And also, I think it's a very important piece that we sometimes forget is to assess the safety of the home. So just because we're letting this baby go home with the caregiver, are there safety nets at home that we have to, make sure that the environment is a good place for that baby to continue to thrive in. So this makes me laugh sometimes when I present this, is that, it took a study to actually tell us that if we follow a standard treatment protocol with stringent weaning guidelines, it will reduce the duration of opioid exposure and length of stay for these babies. So anyways, for what it's worth, follow a guideline and hopefully we can do better. Okay, so I know I've talked for over like 45 minutes already, but I do want to talk about the Yale's Eat, Sleep, Console study, because this is really what the country's going to go towards as we learn how to take care of these babies. So I think it's worth grounding some time on. So this really caught the eyes of everyone when it came out back in 2017. Matt Grossman is actually a pediatric hospitalist at Yale. So he was getting a lot of babies transferred out of the NICU to his floor to manage babies with withdrawal. And so he's like, we've got to have a better way of doing this than these archaic, like Finnegan scoring and giving babies morphine and kicking the moms and dads out. This is just not the way we should be treating these babies. And so he had been working on it for quite a few years. Since February of 2010, he assembled a multidisciplinary team. And these were some of the key interventions that he instituted over the 5-year period. So standardizing how we do non-pharmacological care, having an empowering message to parents that they should be at the bedside, they should help with taking care of these babies. They develop a novel approach to assessment, minimizing the whole Finnegan scoring business. Using morphine only as an as-needed basis rather than constantly blasting them with more morphine postnatally, and transferring patients directly to the inpatient unit, bypassing the NICU, so you are reducing the separation. And it's very simple. It seems very simple, but these were his goals, was that eat, sleep, console. The baby has to eat, so either breastfeed effectively for 10 to 15 minutes or take more than an ounce from the bottle per feed. The baby has to sleep undisturbed for more than an hour. And if he or she is crying, be easily consoled within 10 minutes. If those are met, you just keep going. If it's not, then you start morphine, or if you're already on morphine, you would actually escalate to the next dose. And the converse would be true, is that if the baby's doing well and you're on morphine, then you would actually start to diminish the dose if you are eating, sleeping, and easily consoled. So what he found was that out of 287 infants at Yale who went through this treatment algorithm, the average length of stay decreased from 22 days to almost 6 days. The proportions of methadone-exposed infants, so many of these babies, mommies, were on methadone, and they actually decreased their use of morphine from 98% to 14%. The costs of stay decreased from $44,000 to $10,000, and there were no immediate short-term adverse effects and no readmissions relating to withdrawal. So because this study was published, it caught on and everyone got really excited, including us. But we didn't really want to do it out of context of a clinical trial, because basically we wanted to be rigorous. We wanted to make sure that we're doing it the right way. So we became a site for the NIH-funded ESC study. This was appealing because of its ease of use and simplicity, but really has not been studied outside of QI initiatives. So therefore, there is unknown generalizability. So that's why we should study it. And is the improved length of stay really attributed to the approach itself, or is it just better adherence to non-pharmacological approaches, which also reduce length of stay? And the ESC study, I think this is really the big piece of why I really wanted our site to get involved, is that there has been very sparse follow-up study on this population. However, this study will include a 2-year follow-up with Bailey's exams, frequent surveys about mommy's health, baby's health. And so I think these are really good things that really pushed us into wanting to get involved. So these are actually the lead study investigators. So 3 neonatologists out of University of Vermont, Louisville, and Cincinnati. They wrote up the protocol. Then they basically recruited 26 sites across the country. So I just want to show you what their primary hypothesis is, right? So they are saying that among infants evaluated for NOWS, this new ESC care approach will actually reduce the length of time until the infants are medically ready for discharge by an average of 4 days compared to the usual institutional way. So they're only looking for a decrease of 4 days. The secondary hypothesis was that among these same infants, the use of ESC care approach will actually result in an improvement in infant neurodevelopmental outcomes as well as family well-being. So we'll see if this study actually achieves these hypotheses. And I just put this up there is because it's just something that we put together to try to show how we do this. Again, when you have an infant who is having signs and symptoms, you just keep getting the mom and dad is involved to make sure we're maximizing our non-pharmacological interventions as much as possible. And if it's not, then we will use morphine as a last resort rather than using morphine as a first resort. So out of the 26 sites, we were actually randomized to block 5. This is where the University of Utah is. This is what they call a step wedge cluster randomized design trial. I had never even heard of that. I was like, what the heck is this? So basically, out of the 26 sites, we were divided into 8 blocks, and we belonged to block 5. We just continued our usual care for periods 1 to 5, like we normally had been doing. And then we spent about 6 to 8 weeks learning how to do ESC. It was a lot of work for a lot of nurses during COVID. And so it was kind of interesting. But then the last 4 blocks, we switched over to ESC. And as you can see, the way it's done is that it would be a good, instead of doing randomized trial where you're blinded to what treatment, that doesn't really work in this kind of a setting. So basically our control is our own institutional control before ESC, and then the treatment arm would be after we switch over to ESC. And right now, all of the inpatient data is done. We're in the 2-year follow-up process. So I just wanted to tell you what some of the early results are showing, because it's very, very exciting. Okay, and I'm allowed to tell you because the NIH told me I can tell you. Otherwise, I wouldn't be able to tell you what we're finding. So these are the bottom line. So top 3 points that the ESC study is looking like it's going to show. Until now, there has not been strong evidence to support a standard of care approach for babies with NOWS, because most hospitals have their own way of doing things, but not all the ways are good. But this may actually provide strong evidence that we should be doing this. This study gives hospitals an evidence-based care approach for babies with NOWS. So compared to usual care, the ESC care approach is actually reducing the time the babies are in the hospital, but without increasing the adverse short-term outcomes. I'll show you the granular data on the next slide. And ESC also is reducing the use of opioid medications to treat these babies. So that's the bottom line, is we may actually now have a standard care approach. We are reducing length of stay, and we're reducing the use of opioid medications for these babies. So these are the actual data. The trial enrolled 1,306 infants across 26 sites. And like I showed you before, we were all doing our usual thing, and then we switched over at different time points, but predetermined by the trial. On average, infants that were cared for by ESC were medically ready for discharge at 8.2 days, right? This is astounding. The national average for these babies typically is 21 days. Whereas infants treated under the usual care was discharged at 14.9 days. So we have actually decreased the length of stay by almost a week. The goal, remember, the primary hypothesis was 4 days. So we've actually surpassed that 4-day goal. And then we reduced the use of morphine by 66%. This is again astounding. So out of the ESC group, 17.4% needed morphine versus 50% needed it in the usual care group. So all of these are really, really good things. So far, we've only had safety outcomes for up to 3 months of age, and that seems to be similar between the groups before and after we switched over. And we had to consent for a subpopulation of infants for the 24-month visit and a Bailey exam. So that is actually ongoing. So the longer term effects of this trial we'll be able to know in another probably 1 or 2 years. Lastly is the discharge plan. These are sort of just checklists that I think we should all have before a baby is sent home. And I would say that the piece we always forget is the baby really should be seen within 48 hours of discharge. And I will make a plug here that there is something called the Bridge Clinic at the University of Utah, where it's a group of general pediatricians who have a vested interest in this population of babies. And so if for some reason you're sending your babies home and the mom doesn't have a pediatrician and you don't know where to send that baby, think about the Bridge Clinic at the U if their insurance allows, because those pediatricians are dedicated to taking care of these infants. Don't forget your early intervention referral. That's also, NAS is a legitimate reason for EI referral. Home nurse visits, and if the mom's hepatitis C positive, make sure the baby gets the adequate care by an infectious disease specialist afterwards. And also a developmental behavioral pediatrician referral if it's necessary. I would say another question I get a lot is what are the long-term outcomes of babies with NOWS? And I think it is really difficult to disentangle the short and long-term effects of the in utero exposure from other substances. That's one thing. And also there's so many other sort of non-medical reasons, right? So social economic factors, systemic racism, maternal, physical, mental health, genetic, epigenetic changes, nutritional, environmental factors. All of these will adversely affect the infant development independent of the substance use disorder. And so I think it's really hard to know exactly how these babies will turn out, but just because we don't know doesn't mean that we shouldn't act. I think having these early intervention referrals, keeping close eye on development, having dedicated pediatricians who really care about this population, I would say all of these are really, really good things in order to maximize their neural development. All babies are with opioid exposure are at risk. So like I said, refer to early intervention, early Head Start programs, and some of the other developmental resources that we can always rely on. That is all I have. I am open for questions.
If there are any questions, if you just want to come unmute or put your hand up, Dr. Fung will take those questions. What a wealth of information. Thank you so much on that. I just saw someone turn on their camera just recently. Natalie, was that you just popped up on my screen as turning on your camera? And did you have a question? No.
I didn't. I just turned on the camera. Yeah.
Okay.
I like to see people's faces. Thank you. I don't know, was this helpful for the group who is in attendance?
Oh, yes. And Crystal, it looks like you came unmuted.
Yeah, I just was wondering, do you know how many NICUs are using the Eat Sleep Console?
Yeah, so this has really taken off more in like the northeast of the country. I think when our paper comes out, I would hope in the next month from the New England Journal of Medicine, I think a lot of people are going to want to go towards that. So right now, not as prevalent, but I think that's going to be a skyrocketing adoption of this Eat Sleep Consult protocol. And that's why I wanted us at the U at least to get on board, because think we had this hunch that this was going to be the way to go. So let's do it in a trial setting where we're actually taught by people who wrote up these protocols, and we had, champions who really taught us, the nurses really. This is going to fall onto the bedside nurses who are taking care of these babies, because they do a lot of these huddles. Basically, when a baby is having symptoms, you huddle with the mom and dad, and you try to see if all of the non-pharmacological interventions are maximized. If they're not, then you do that first. And you basically do 2 rounds of huddles before you even think about pulling out a medication. So I think this accomplishes also is empowering the parents. If they know what they can do to calm that baby while they're in the hospital with the nurse's help, I think that's only going to do a wealth of good when that baby goes home. That mom isn't going to be frantic when that baby starts to cry, because she's done it in the hospital, right? So I think it's probably going to be the standard of care.
So, and then a follow-up question, how can early intervention help these families to transition? And make it smooth.
Well, I still think that you guys need to continue to help these mothers, right? Because a lot of these moms, what at least I've heard is that just because the babies get out of the hospital, they are still going to have periods of irritability. And, I think the baby's brains are still trying to normalize their own neurotransmitter system. So it's not going to be smooth sailing just because you got out of the hospital. I think we still have to have you guys from an outpatient standpoint to continue to help these mothers, help them define what normal is, because sometimes they may not even know what normal is. So I think the outpatient piece must continue just because the baby got out of the hospital. Does that help? Basically, yes. Please continue to stay involved.
Thank you. It does help. It's on the chat. It does help to know what's happening there so we can help kind of continue to support at home.
And one other question, does Primary Children's go along with U of U in this? Are they doing the training or the ESC also?
That's actually a loaded question. I'll tell you why. So when this trial was coming down the pike back in, it was like 2019, and somehow I was in charge of figuring out who was doing this, both at the U and primaries. And at that time, we were actually, when we started doing it, it was right in line of COVID. I think it was when we really got going, it was like March of 2020. And so the U, we continued, but Intermountain decided that they would spend their energy doing something else because it was going to be so nursing heavy. They wanted to reserve their nurses for COVID combating rather than learning a process that may help babies. So to my dismay, it did not happen across the Intermountain system, but I know that Liz O'Brien, she's the head of women's and newborns. She has already approached me to see if we could somehow figure this out for the Intermountain system. I just have to figure out how to do it because I don't have all of that resources that was available to me when we were doing it for the trial. I mean, there were so many intensive modules and videos and people watching each other. I mean, it was a lot of work for a lot of nurses, and I'm so thankful for the university nurses for participating. But that level of intensity, I don't know if I can reach that on my own without support. So we'll have to see how it goes. I'm going to try.
Dr. Fung, sorry, I'm Natalie Allen. I'm a pediatric nurse practitioner, and I mostly deal with these kiddos when they get a little older. And I guess my mind is thinking, because I was a NICU nurse back in the early 80s, and I remember when we changed to developmental care in general, things just changed enormously. And I believe that the outcomes, we've seen better outcomes for kids in general. my excitedness is like, will we see less problems for these kids later on because their little nervous systems were better tempered? I don't know. I'm excited to see and hopeful that we have better outcomes on the other end. So thank you for this presentation. It was wonderful.
Yeah, so I think that's why I really wanted at least somebody, whether it's the U or Intermountain, for us to participate, because they have this really robust 2-year follow-up that I have not seen in the literature, where, you know, a lot of people describe what happens in the hospital, and then it's like this black box, the babies go away and we have no idea how they do. But this trial, we actually have a good amount of babies who are consented for the 2-year follow-up. We'll see. I mean, I don't want to speak to or jade you with any ideas, but I went to 2 of these Bailey exams actually at the U, and I was hoping that the babies will actually do better, but I don't know. I think kind of what you're worried about is the in utero exposure really the driving point of what happens to them. The postnatal environment. I mean, these are kids who have moms and dads who are, you know, they're together, they want to do the best for their kids, but at least the 2 Baileys I watched, the kids are not normal. I mean, they're still having issues. So I don't know. My N of 2 does not speak to the whole clinical trial, but we'll see what the, you know, eventual outcomes look like. But it made me worry, put it that way.
Okay, well, I have plopped in the survey in the chat, so if everybody will please take a minute to complete that survey. Dr. Fung, thank you for that wealth of information. I just love listening to it all the time. And I'm not seeing any other questions, so thank you, everyone. We will be meeting again next month, March 8th. Can you believe it's the exact same date in February and March? So March 8th at noon, and I'll be sending out a follow-up email with the survey link. So I'll continue to plug for that survey. If anybody has a case presentation that they are interested in sharing and gaining more information about, please reach out to us at projectscope@usu.edu. And thank you, everyone. Enjoy the rest of your afternoon.